Thank you so much for coming to the inaugural ARCHtalk. I'll explain in a couple of minutes what ARCH is and why a talk would be inaugural associated with this initiative. But I just want to say, first of all, thank you so much for coming. It's so wonderful to see such a packed house in here. We have such an exciting talk coming to us from one of our most distinguished alumnus. We have some exciting news to share about what's been going on with the ARCH Innovation Exchange and what our faculty have been up to. So I'm Dr. Bridget Chalk. I am interim provost at Manhattan and also a professor of English. This talk tonight is the first in a series of discussions that highlight innovative leaders of industry and groundbreaking scholars. The series is part of the brand new ARCH Innovation Exchange at Manhattan University, and I want to tell you a little bit about what that is. So ARCH stands for Analytics, Research, Creativity, and Humanity. These are fields we feel will help determine the future of society. ARCH also, as you may have guessed, refers to our beautiful architectural signature, the brick portals leading from our entrance to our picturesque quad. On this vibrant quad, students mingle with faculty and staff on their way from an economics class to a history class, or from a physics lab to a class on great works of literature. So all of these classes represent different ways of thinking about the world. And so ARCH is a framework. It is a framework for new initiatives that are three major things: innovative or inventive, interdisciplinary, and experiential, plugged into the real world. So we believe that the more perspectives you have, all these different ways of looking at the world that are represented in physics classes, in history classes, in economics classes, the more perspectives you have, the better positioned you will be to think in inventive ways, to solve the major problems, and succeed along any path your life takes you. So in this spirit, we have ARCH. The workplace is not divided into majors, and your education should not be either. And so ARCH is a way for students and faculty to work across majors and departments to address the grand challenges facing us today: renewable energy, sustainability, achievement gaps in education, health equity, just to give a couple of examples. None of these problems can be solved using one discipline. So this bubble map shows you how ARCH is already functioning on campus. How do we already have an innovation exchange based on our faculty, our classes, our programs? So you can see that ARCH is at the center, and all of these bubbles that are coming off of ARCH fit the three major categories: innovation, interdisciplinary study, and experiential learning. I want to highlight one bubble up here, the Faculty Fellows bubble, because I'm proud to announce that we have just appointed the first class of 2026 faculty fellows, ARCH faculty fellows. So we have a group of faculty who propose projects that are, again, interdisciplinary, innovative, and experiential, and they will be receiving a stipend to work on these projects over the course of the spring 2026 semester. Dr. Lawrence Udigwe from our mathematics department, he's waving. So Dr. Udigwe will be guiding these faculty fellows through their projects. He will be holding workshops. He will be sharing with them research on how to conduct this kind of learning, of pedagogy, and of research. So I'm going to announce the fellows. Some of them are with us today. Dr. Wafa El-Manai, if you could just stand quickly, Wafa. She's a professor of electrical and computer engineering, I should say the chair of that department, and she will be working on an interdisciplinary AI research cohort. Dr. Lydia Crafts, is Lydia here? Lydia is in the history department, and she will be working on an interdisciplinary minor in health humanities. Dr. Laura Reggiuello is here, I know. You could stand, Laura. Thank you. And she will be working on an international academic collaboration initiative for global online learning, where students can connect with students in other countries to work on projects together. Dr. Patrick Abulencia, I know, is here too. He's from the Department of Chemical Engineering, and he will be working with the School of Business in order to construct a course sequence on entrepreneurship for society. So that will cross over the School of Engineering and the School of Business. Dr. Manaz Afridi is here, I know, and Dr. Christy Gonzalez Tora is not here, but they will be working together on a series of faculty workshops on embodied learning and inclusive design. So figuring out different ways to train faculty to make accommodations for students in their classes. And finally, Dr. Jay Friedenberg will be working on a Center for Existential Risk. So this existential risk might look like climate change, pandemics, disinformation, right? So showing students how to navigate these sorts of risks that we face today. So speaking of existential risk, we have a extremely wicked problem, grand challenge in our world right now, and that is the advent of artificial intelligence, and specifically generative artificial intelligence. How do we grapple with the lightning quick development of this technology, which is boosting the stock market, but threatens to eliminate millions of jobs? It has miraculous capabilities, but existential implications. So other paradigm shifting technologies completely transformed daily life for humans in the past: the railroad, the telephone, the electricity, the computer, the internet, and AI seems poised to do the same. The question is, what will that look like? How will life be transformed? We don't know yet. Many of the jobs that exist today, for college graduates in particular, will not exist tomorrow. In fact, we can assume that a major portion of the jobs you all students sitting here will take on haven't even been invented yet. If you think about roles like prompt engineer or influencer, right, or sustainability specialist, these were unheard of 10 years ago. So the question is, how do we best prepare students to navigate this new world? As I said, one of the most consequential innovations in our era, or most of the consequential innovations, involve emerging technologies. So to that end, we are planning the innovation engine as a part of ARCH. So the innovation engine is going to be a series of spaces and project areas and technology spaces that are designed to foster active learning through experimentation and exchange with students and faculty. So I'm excited today to share with you some renderings of what we expect this space to look like. It will be housed in Leo Hall near the School of Engineering, but it will be a space for all of our students, no matter their major, to come and work with faculty on a variety of projects involving emerging technology, involving VR and AR, and a host of other emerging fields. So this is the floor plan. This is an initial vision of what we think the innovation engine will look like. So it will have a space that you can look in to see what everyone is doing. It will have making spaces, it will have equipment, it will have space for students to gather, to collaborate, and to come up with the next great ideas. So we are actively fundraising for this space. If you will look out, those of you alumni and other community members in this room, if you'll look out for communication about this campaign, we're excited to further develop this vision and bring this reality to Manhattan University. So this is one way we can prepare for the future, exposing our students to these different forms of technology, right? Giving them ways of engaging with this, hands-on, experiential ways with expert faculty. Michael Crow, who's the president of Arizona State University, says the best way to prepare students for the future is to cultivate adaptive master learners who can integrate a broad array of interrelated disciplines and negotiate over their lifetimes changing workforce demands and continual innovation. So that notion of being an adaptive master learner, being able to navigate and negotiate among many different existing fields, but also those that are yet to emerge, is something that is very difficult to prepare for, but nevertheless, being on a college campus is a place to be able to do that. And so that's what ARCH aims to do as a supplement to your majors and minors, prepare you for the workforce of the future. So our honored guest tonight, as you will hear, is proof of concept that an illustrious career is not limited by a singular field or major. Rather, it's defined by a variety of areas of expertise and the ability to lead and innovate, not only within an industry, but across industries. So we're lucky to have him here tonight as part of the Jasper family. I'm going to now ask President Bonato to come to the podium to introduce our featured speaker this evening, Dr. Anthony Mercando.
Now I know why you didn't use this, because it doesn't fit. It's a great privilege to be able to come here tonight and introduce our inaugural speaker for the very first ARCHtalk. But before I do that, I want to acknowledge the person who started this, the idea, and that's Dr. Bridget Chalk, this is her idea, and it's a great idea. So thank you very much. The ARCH Innovation Exchange is an initiative grounded in the belief that the most meaningful innovation occurs at the intersection of disciplines. It is fitting that our first speaker embodies that very integration. Dr. Anthony D. Mercando is a member of the class of 1976, and his undergraduate degree is in electrical engineering. Is there a picture of him? Okay. He's a practicing cardiologist at White Plains Hospital Physician Associates and serves as director of AI strategy at White Plains Hospital. After earning his bachelor's degree here at Manhattan, he received his medical degree from Harvard Medical School and the Harvard MIT Division of Health Sciences and Technology. He completed his internship, his residency, chief residency, and fellowship in clinical cardiology at Montefiore Medical Center in the Bronx. And he has practiced cardiology in Westchester for more than 35 years. Dr. Mercando is board certified in internal medicine and cardiovascular disease and is a fellow of both the American College of Cardiology and the American Heart Association. He has served as clinical professor of medicine at Albert Einstein College of Medicine and associate clinical professor of medicine at Columbia University, teaching and mentoring generations of physicians. Throughout his distinguished medical career, he's maintained a deep interest in technology and its role in advancing patient care, a commitment that now informs his leadership in artificial intelligence strategy while he continues active clinical practice. His work exemplifies the integration of engineering, medicine, and innovation that ARCH is designed to explore. Dr. Mercando also generously supports Manhattan and is helping to fund the Electrical and Computer Engineering Lab here on campus. Thank you for that, Dr. Mercando. Thank you. Please join me in welcoming a distinguished alumnus, physician, educator, and leader in healthcare innovation, Dr. Anthony Mercando.
Hi, folks. Okay. Well, it's a privilege to be here, and I am privileged to have been invited to give the inaugural talk in the ARCH initiative. I want to thank President Bonito, Provost Bridget Chalk, Assistant Provost Bruce Libby, Dean Catherine Jabloko, of the School of Engineering, who I spent a lot of time with today, and she showed me around the whole engineering school. I haven't been here in probably 25 years at the campus. Some things haven't changed in 25 years, but we are trying to change those things. I also want to thank the many people from Manhattan University who were instrumental in the ARCH program. When I heard about the ARCH program, I was really just a believer in it, and I just felt that it was so much like my life, my career, and that's why I'm so happy to be able to share some of that with you tonight. I also want to thank Adrienne Billis, who is here somewhere. There she is in the back, who's put many of the day together here, and Bill Lipson from the Development Office, who really has been tireless in putting this day together. I want to thank my colleagues from White Plains Hospital and Montefiore who've come here. Thank you very, very much. I want to thank friends from Manhattan, including the professor, my former professor, who's in the audience here. I'll pick on him later on. I also want to thank professional and personal friends and call someone out in particular, my friend Tony Medallo, who is a friend of 65 years. Also a graduate of Manhattan College, and we've actually been together for that time through grammar school, high school, college, and he is now a practicing physician at White Plains Hospital also in orthopedics. I want to thank the faculty who are here and the students who are here, and of course, my wife, Leanne, who is here. I want to thank her too. So what I'm going to be talking about tonight is artificial intelligence in healthcare. The good, the bad, and the ugly. There was one of the board members who I work with at White Plains Hospital saw the title and said, that's interesting. 2 out of the 3 topic areas are negative. And I said, well, now, not really, because you're going to see that I give unequal weights to these 3 areas. And I hope to share with you my knowledge of and vision of artificial intelligence in healthcare, and I hope to instill in you that the good far outweighs the bad and the ugly, but we have to deal with all of these things. I'm going to try to keep my talk as brief as I can. We're going to talk about a little bit under the hood of AI, some examples of AI in healthcare today and in the future, real benefits. Where is AI better than humans? And some of the limitations. Where are humans better than AI? We'll talk a little bit about the bad, dangers of overdependence on the technology, how we can be sure AI is doing the right thing. Very, very important in healthcare. Just think about it. We'll also talk about some of the ugly, some of the medical legal issues, and some of the ethical issues. And then I'd like to speak briefly about how can or should Manhattan University lead in this area with the ARCH initiative, why all students, I believe, and faculty need to learn about AI now, why we should be a leader in this space. What makes Manhattan University particularly good at doing the things that we need done in AI today, fighting the bad and the ugly. And then what is and are the secret weapons and secret sauce that Manhattan University has, I think, above a lot of the other universities in the area, and also how alumni can get involved. So first, let's talk about the good. So this is a photograph I took off the coast of Antarctica. Many, many icebergs, beautiful trip. My wife and I went there about 2 years ago. And inevitably, one of the questions I was always asked about is, did you see any polar bears there? So then I show this picture that I made. Anybody think something wrong with that picture? I think it's a nice picture, but no, it can't be a real picture because there are no polar bears in Antarctica. There are lots of penguins. There are no penguins in the Arctic. That's where the polar bears are. So how do we get this picture? And I say you're as likely to see a polar bear in Antarctica as you would be to see a leopard. Now, this is a photo that I created using AI early on, just after our trip. It's a nice photo, but let me go back to this photo. So this was one that I created a few months later using one of the AI models, Grok, actually. And it is incredible. It is a true fake. You obviously can't have a leopard on an iceberg or the polar bear down there, but look at it. For those of you who are photographers in the audience, that's an incredible photograph, okay? There's the true blurred background, bokeh. There are reflections in the water that you could see there. This was something created by AI. So AI can be a lot of fun, but it could also be pretty dangerous. So what is artificial intelligence? Artificial intelligence is a broad field of computer science and technology. That's what it is. And it focuses on creating systems and machines that are capable of performing tasks that typically are done by humans requiring human intelligence. And that could be learning, reasoning, problem solving, understanding natural language, perceiving the environment, and then making decisions about what it sees in the environment. I'd like to point out, though, that AI, although it seems like magic, is really not magic. AI is the magician. And if you think about that, whenever you use ChatGPT, whenever you try to create a great one of those true fakes like I created before, to think about this, it's not magic, it is the magician. And I'll show you a little bit about that later. It really is only math. Who's the mathematics professor here in the audience here? Well, so this is the math, some of the math behind AI. And if you look at that math, there are summations there are partial differential equations, all kinds of tough stuff that the engineers spend a lot of time doing. But that's all AI is. It's math in the background. And that has really proven the point with this chart, which I'm showing here. This is the closing cost of the company NVIDIA from its founding around the late 1990s. And you could see there, way down there in the beginning, we're talking about the stock worth about $1 in today's terms. But now, up until today, the stock is now worth close to $200 a share. Why? It's because NVIDIA, which was a company founded to create chips that can display images on computer screens, happens to be able to do math very well, because to display those images on computer screens, especially if you're doing gaming, for instance, requires a lot of mathematics. So NVIDIA chips can do mathematics much more efficiently than a central processor can do in a computer. And so that's why NVIDIA is doing so well, because people are buying their chips like crazy to be able to build data centers that can do AI. AI is all around us. If you don't think you're using AI, by the end of this slide, I think I'm going to convince you that you are. If you have a self-driving car, Tesla, about a year and a half ago, switched all of their code for self-driving from C++ to AI. And they took hundreds of millions of lines of C++ code and converted that into an AI model. So now if you have a Tesla, self-driving Tesla, it's using AI. Search engines, you do searches on Google now, it will automatically do AI search for you and give you a very different type of answer than you used to get just a few months ago. Fraud detection. Every time you use a credit card now, it is going through a fraud detector, which is using AI to determine whether or not the pattern of your spending fits with what you've been spending in the past. And if not, it can flag those as fraudulent transactions. Spam identification is totally done by AI now. If you use, for instance, Gmail, it's totally AI. Personalization, ads. You know, it's sort of spooky when you see ads come up about things that you've been searching for or thinking about or talking about. A lot of that is done by AI analyzing, and also Netflix showing you the next movie that you might like. Speech recognition, which I've been using for about 20 years, more and more has become AI. It is incredibly accurate now. And it's accurate whether you have an accent, whether you speak, whether you're a slow talker or a low talker, or whether you are a loud talker. It uses AI now to do speech recognition and to do things like the conundrum of 222, right? TO, TOO, and TWO. It uses AI to try to determine which of those you mean. Face ID on your phone, photo searches. You could search all of the images on your phone now using AI photo search. Alexa, Siri, RoboVax use a lot of AI to determine where your steps are and to make sure they don't go down the steps or bang into walls and furniture. Language translation. The day is just about here when we can have a conversation with somebody speaking a different language in real time. And you can talk to them in your language, they hear it in their language, they talk to you in their language, and you hear it in your own language. Wearable technologies, all the things you wear, your Apple Watch, your various Fitbit trackers, a lot of that is using AI now to determine whether or not something is going wrong with you. How many of you get a report every day about how much sleep you've done? How effective has your sleep been last night? This is all from wearable technology. And then, of course, there's the GPTs, which are like ChatGPT, Gemini, Claude, and Microsoft Copilot, which are generative pre-trained transformers, which are taking information that they've been changed, taking your question and answering using new information. But of course, artificial intelligence is no substitute for real intelligence, and it never will be. This was from the IBM Watson Research Center. So there was an article in the Wall Street Journal about 2 years ago, front-page article about nurses and AI getting into nursing in healthcare. And I wrote a letter to the editor, and my point in the letter was that AI is coming into healthcare right now, but AI should be a tool, just like any other tool I use, a stethoscope, an electrocardiogram. It's just a tool, because you still need the human element. And so I pointed out, it's in that third paragraph there, that about my grandson who was born in London. My kids were living in London at the time. He was a preemie, born about 2.5 months premature, got excellent care in their neonatal intensive care unit. And one night, 4 days after he was born, the neonatal intensive care unit nurse didn't like the way his blood was clotting when she was pricking his heel for blood tests. That's how they take blood on infants. And so she took it upon herself to send off blood tests for clotting, and found that he was a severe hemophiliac. He was one of the youngest people ever diagnosed with hemophilia. Remember, he was 2.5 months preemie. Happened to be in the Hemophilia Treatment Center of London, thank God, but she identified this. AI would never have been able to identify this. It was a feeling that the nurse had, her intuition, and she sent off the test. So there's a spectrum in AI in healthcare from fear to overenthusiasm. Okay, but really the truth lies somewhere in the middle and involves managing change. How do we get people to use AI correctly, to use AI responsibly, and to make sure that AI is doing the right thing in medicine? So there are a lot of components of AI. I'm going to go through these real quick. You don't have to read the slide. Machine learning, which is a subset of AI where machines are trained to learn from data and improve their performance on specific tasks without actually being programmed to do that. Deep learning is a type of machine learning that involves what we call neural networks, trying to mimic sort of what the brain does with many interconnected layers. I'll show a little bit about that in a minute. Natural language processing is one of the AI concepts. It focuses on enabling computers to understand and interpret human language. Computer vision, very, very important when we start talking about robotics. It's a field that enables computers to interpret images that they see. Robotics itself is is getting the computer then, or the AI, to actually do something. And that's what the field of robotics involves. There's something called retrieval augmented generation, which is a framework of AI that optimizes how large language models can generate answers by giving it extra information that a typical model may not have to do a specific task. We're using this a lot in healthcare. And then there's something called reinforcement learning, where the AI is taught by giving it feedback in the form of rewards and penalties. But in a nutshell, AI is simply, you give me an input and I give you an output. And that's all it is. And for instance, the input could be a text question, as you would type into ChatGPT, and it gives you an answer. It could be an image, like an X-ray, and you're answering a question, is this cancer or not? It could be using it for identification. You know, the slides are not exactly demonstrating here properly, but that's okay. The point is, it could take an image and identify what's in the image and then give you an answer based upon what's there. So there's an input and there's an output, an input and an output. And what is in the middle? Very easy, right? A black box. And that's one of the problems with AI. Sometimes when AI is trained, you have no idea what it is being trained to do. You have no idea how it's coming up with its answers. It's a black box. But inside that black box are all of these interconnected layers. And each of these dots represents a feature that is a mathematical weight, that carries a mathematical weight based upon all these arrows which are doing calculations. Again, NVIDIA chips doing these calculations very, very rapidly. So these hidden layers in between could be in the millions, the billions, the trillions even. But that's all AI is. And AI needs lots of data to train it. We need to give it a lot of data. If you start out with very little data, your accuracy is not going to be very good. That's on the left-hand side of the slide. If you give it more and more data, you reach an asymptote where giving it more data beyond that is not going to help your model very, very much, but you need lots of data. AI is only as good as the data that it's given. Now, there's supervised learning and there's unsupervised learning. So supervised learning would be using labeled data sets where you say, this X-ray has cancer, this X-ray does not have cancer. So feed it 1 million X-rays that have cancer and 1 million X-rays that don't have cancer, and then have the machine come up with what it needs to do. And there are classifications and regressions. And then there's unsupervised data, where you just feed the model lots and lots of data, and it will basically come up with patterns in the data. And here's like patterns we can't see. And so this is where AI sometimes is a bit of a black box, and we have to be careful about that. When I was a little boy, we trained computers by teaching it specific things. So for instance, if I want a computer that could identify a cat, I would create a program that said, okay, these are the features of a cat. It's an animal, it has 4 legs, 2 ears, it has fur, et cetera, et cetera. And that's traditional programming. That's what I learned when I was in school. Around 2012 to 2015, because of work done in several companies, including Google, we started to get to the point where we trained models of neural networks by showing it examples and saying, this picture's a cat, this picture's not a cat, and then show it an unknown and say, is this a cat? And that's the models that were available a few years ago. But now we have these generative models. With generative models, you say, okay, go out and look at this huge corpus of information. It may be all of the information that's on the internet. It may be all of the New York Times articles from the last 25 years. Whatever it is, you're giving it huge amounts of information, and then you say, okay, so what you've learned about cats from all of this information, tell me, what is a cat? And is this a cat? And that's the generative models that we're up to these days. So let's talk a little bit about where AI is being used right now in healthcare. So it's being used a lot in imaging because of that pattern recognition that I just showed you. It's used in radiology. It's also used in pathology. It's used for predictive analytics. So we were looking at a system that would predict when somebody walks into the emergency room whether or not they will require certain services like hospitalization or certain expensive testing or complex testing. Predictive analytics, using it a lot now. Personalized medicine to create a digital you where we can try things out. So I have the digital you, and I've fed all the information about you, and now I say, what will this drug do to that digital twin? So we're getting into more and more of this personalized medicine. There's also virtual health assistants, telemedicine. It's being used in drug discovery. What's the probability that this compound is going to have the characteristics and produce the outcomes that I think it would produce based upon other compounds that are similar to it? So that's drug discovery and development. It's also being used to help with clinical trials and research, health monitoring and wearables, detecting if somebody is going into heart failure because of some pattern that their watch or their phone is telling us about. They're not moving as much, they're breathing faster, their heart rate is going up, they're spending more time supine rather than up and about. So that's remote monitoring and helping with chronic disease management. Robotic surgery, the company Intuitive, which builds the Da Vinci robot, is starting to incorporate more and more of AI to assist the surgeon there. It's being used in mental health and behavioral analysis. One of the students that I met with before is thinking of going into psychiatry, and we talked about that. We looked at a product that can listen to an encounter I have with a patient, just the conversation I have with a patient, and tell me probabilistically whether that patient is depressed right now. And that is the excitement of AI, being able to do something that I can't do just listening to that patient. Sure, if I ask the patient, you know, you're thinking of jumping off the George Washington Bridge, and they say yes, yeah, you're probably depressed, but not through subtle conversation. Very, very interesting. It's also being helping out with healthcare operations and administration, and natural language processing is everywhere in healthcare. Here's an example of one of the products we're using. This is an electronic stethoscope. Stethoscope was invented hundreds of years ago, and every cardiologist uses it, and most other doctors use it to listen to the heart and the lungs and other parts of the body. Well, this electronic stethoscope can record in 30 to 60 seconds a patient's heartbeat. It then goes up to a model which was created with the help of Mayo Clinic, and that model can now report back about the probability that that patient's heart is malfunctioning. That patient has heart failure. I can tell you, I can't do that on physical exam as a mere mortal, but this is one of the features that they have, and it's up to about an 80% accuracy right now, which is really very good as a screening test. Here's another product we're looking at the hospital, ready to implement, something called US2.AI. Ultrasound to AI. It's a company that was formed to be able to read echocardiograms using AI. It's an FDA-approved AI solution that automates interpretation of echocardiograms. If you've ever had an echocardiogram, that's about a 5-minute video recording that the technician will do. It's a sound wave test of your heart. Well, we take that 5-minute video recording, send it up to US2.AI, and it gives us back in 90 seconds about 45 readings, measurements from the echo, plus some interpretation, and more certain features are being added to it that it can identify and diagnose things that we cannot do as mere mortals right now. And it's very, very explainable, because what it does is it gives us the measurements on the left-hand side, but then it shows us how it made the measurements on the right-hand side, on the images. And an echocardiographer, the physician then, who's reading the study, can then agree or disagree with that, move the parameters around to change one of the measurements if necessary. But it's now to the point where it's actually interpreting those measurements and giving us a reading on what the measurements mean. This is another system which we are about ready to release now at our hospital. We're working on it right now. It's a system called AskMed.ai from a company called Atomo. If you start out in the middle of the slide here, AskMed.ai is a conversational interface that's been fed certain data. Besides the usual ChatGPT type data, so it can understand what you're talking about, it also has healthcare claims data, encounter data. So things like pharmacy claims, hospital claims, outpatient claims, about 350 to 400 million of those. It also has on the bottom in yellow, PubMed, where it says PubMed. It's been fed the corpus of medical literature from PubMed for the last 7 or 8 years. So it knows all of the medical literature. And then on the far left-hand side of the slide, on the yellow box on the top, it is data that we have given to the company. So that's White Plains Hospital data, which is data coming from our electronic medical record. Now, this data is highly secure. It is de-identified. It is data that, again, a human being cannot really make much of. Okay, and if people are interested in what data it is, I can talk about it later on. But it's not data where you can identify who the patient is. And it's all done encryptedly, and et cetera, et cetera. And they're going to take this and they're going to give us a list of patients who may have a disease which we think is fairly rare called cardiac amyloidosis. It's a disease which we're really not sure of the prevalence because it's so difficult to diagnose. And it's difficult to diagnose because it has so many features to it that can be seen in other people who don't have the disease. For instance, lower back pain. Who's got lower back pain here, right? Carpal tunnel syndrome, certain types of neuropathies. So these are common things. It doesn't mean you have cardiac amyloidosis, but in the right setting, these are things be associated with cardiac amyloidosis, difficult to diagnose disease. So we are proactively trying to find these patients who most physicians have not been able to diagnose. When they did this study at University of Pennsylvania, they found about 250 to 300 patients in their data who had not been diagnosed with the disease. Now, the importance of diagnosing it is because we now have treatments for it. And these treatments can actually prolong life and reduce symptoms. So that's what we're trying to do. But we could do other things with AskMed.ai. We can actually ask it questions of our own data, and it then gives us an answer. Like, you have 6 patients in your practice with, and whatever disease you put in there, and 2 individuals with another disease. Moreover, there are 6 possible yet to be diagnosed patients. Do you want their medical record numbers so you could look them up and try to get them taken care of? So this is proactive healthcare. So we've given them this database. They're crunching the data right now. They're going to give us this list, and then we have created the protocol for re-identifying the patients back at White Plains, and then contacting the patients through their internists or their cardiologists. If they don't have internists or cardiologists, trying to get them the care that they need. And then we're going to evaluate how this basically has panned out. This is something we're using right now at Montefiore and White Plains. You may have encountered this in your own doctor's office. This is called ambient scribe, okay, which it means, and we're using a system called DAX, or Dragon Copilot, which is a Microsoft product right now. Microsoft bought this company. Dragon is a speech recognition software that many of you may have used for years, but Microsoft bought the company, and this is another product of that company called Dragon Copilot. So when you come to my office, I put a phone between the two of us, and it listens to our conversation. And then at the end of the visit, I press a button, and within about 30 seconds, it writes the note for that visit. It doesn't just transcribe the visit. It actually writes the note, puts things in the right place. So I can be talking, and many patients talk to me, you know, they tell me about their toe one time, and they tell me about their heart another time, and back and forth. It will put things in the right place. And it's been very, very, very useful for me. I've used it over 3,000 times. We always ask patients permission to be able to do this. In that 3,000 times, only 1 patient has refused, because this is something which will help patients. But In the back end, we are very, very careful about cybersecurity here. And we have very, very strict protocols with the companies we deal with through Montefiore and White Plains to make sure that, for instance, this data is not used to train models that are going to be used in other products and other hospitals. And two of our instrumental individuals here from Montefiore who have been working on this project for a long time are here at the talk today, and I thank them for coming. This is really changing medicine, because in the future, what this is going to do is it's going to act as a real co-pilot to me, which is the holy grail of what I do with AI. It's going to start looking through your chart as I'm talking to you, and it's going to say, hey, Joe here has not had his colonoscopy recently, or hey, Joe's creatinine has just done this from 1 month to the next. That could indicate that something is happening, or it could indicate that one of his drugs is causing a problem. So it's going to be a true co-pilot to me and tell me about things that I just don't have time to encounter and consider on every 15-minute visit with a patient. It's going to be beneficial for everybody. We're using it a lot in radiology. This is something which we're about to implement called fracture detection. Fractures are usually easy to see, but many times can be very, very subtle. And if somebody's trying to read lots of studies, a radiologist, they may miss fractures. So this is going to be a co-pilot to the radiologist looking over their shoulder to find fractures, perhaps subtle fractures, again, using that pattern recognition that AI is so good at doing. Here's another example, looking at CAT scans of the chest to identify nodules. These little white dots that you see on the right-hand side of the chest image, those are nodules, and it's going to help find the nodules, compare them from one study to the next, and give us information about it. But one other feature of the software that we're looking at is something called coronary artery calcification scoring. I think a lot of people are familiar with this because it was publicized in the New York Times over the last couple of months. It's looking for calcification inside the coronary artery blood vessels. And ordinarily, if you want to have that test, you have to have a special CAT scan that just looks principally at the heart, and it comes up with a number. And the number helps me put patients into one of 4 categories. One category is 0, that's good. One category is 300, that's bad. One category is 100 to 300, that's, bad. And if there's somebody who's aggressive at treating, I really think it's important to treat those patients. And then there's 1 to 100, which is a category where, you have to have a conversation about how aggressive you want to be. Personally, I would want to be very aggressive. But right now, you have to do a special CAT scan to get that number. And that's the number I need to decide how to treat you. So having the information that there happens to be calcium on the study, like you see here, doesn't really help me. I really need to see what that number is. So the AI software can take a CAT scan done for any reason and give you that number. Okay? So this is something called opportunistic screening. It's screening people for one disease, which is very common and could be very deadly, when you're looking for something else. You're looking for another disease. It's being used for retinal imaging to diagnose diabetic retinopathy. Very, very good at this. And there are several systems out on the market today which can do this. They do it very efficiently, very quickly. And then there's analysis of electrocardiograms. This is an electrocardiogram, which your doctor may do if you go into the office. You see those big spiky things on the electrocardiogram? Those are your heartbeat. Okay, that's when the heart is beating, is contracting, okay? And most of the analysis that we do on electrocardiograms focuses on the space just before and just after those spiky things, okay? But I've said it many, many times. I think there is a lot of information in between the spiky things. So those lines that appear in between the QRS complexes or heartbeats, I think has a lot of information. And in fact, this is some of the things that it's being used for. It's being used for heart failure detection. I can't detect heart failure on an EKG right now. The human eye cannot do that. We don't have a measurement that we make that tells us that somebody has heart failure. But there are algorithms now that can read EKGs and identify patients who may have heart failure. Atrial fibrillation, I think a lot of people know what atrial fibrillation is. It's a hot diagnosis that's out there, right? Everybody talks about it. It's diagnosed by Apple Watches a lot of times. The electrocardiogram I showed you did not have atrial fibrillation on it, but there are now algorithms that can look at an electrocardiogram in normal rhythm, which is what I showed you, and detect the probability that this patient may have atrial fibrillation in the future. And so this is something which excites me as a cardiologist, because again, we could be proactive about finding these patients. Why do you care? Well, because patients who have atrial fibrillation and don't know about it could have blood clots in their heart, and that can develop into a stroke. So that's why we need to find these people. It can also flag possible other structural heart diseases that I can't diagnose accurately on an EKG right now, such as hypertrophic cardiomyopathy, if that means anything to anyone, and also cardiac amyloidosis, that disease I was telling you about before. But it's interesting. You can look at an EKG and put it through AI algorithms that can tell you the patient's biological age, their sex, and whether they have electrolyte imbalances, like high potassium levels. Okay? If somebody's potassium is very high, I can diagnose that on an EKG. But if it's subtly high, I can't. But AI algorithms can do that. And then there's AI in arrhythmia detection. This device here is called an implanted loop recorder or an implanted cardiac monitor. Okay? It's about the size of your pinky, or maybe 2/3 of your pinky. It's implanted under the skin. It has a battery which can last from 3 to 6 years. And it monitors your heart rhythm 24/7 during all of that time. And if it detects an abnormality, it records it and then sends it to a central location, usually the company, and then the company will send it to the clinician. So up to now, most of the algorithms for these things were just based upon probability. For instance, in atrial fibrillation, people's pulse tends to be irregular, so the probability that they have atrial fibrillation based on an irregular pulse. But they now have powered by AI. So this is an example that came through just the other day on a patient of mine. This is atrial fibrillation. But for those of you who are used to looking at waveforms, there's lots of noise on this waveform, and you can't help it a lot of times. You could filter all you want, but you can't always get rid of all that noise. So how do you differentiate the noise from the real spiky things that are there? You use AI. And in fact, in this particular study that was done in 135 patients, before their AI algorithm was implemented, and then after, I want you to concentrate on the second line down, specificity. Okay, so sensitivity you want, right? You want to be able to pick up everything, even stuff that may not be real. Okay, that's something you want. But you don't want a lot of garbage in there, so you don't want it picking up stuff that's not real. Okay, so you want the specificity to also be high. And so if you go from the first column to the second column, 83.3%, it increased it to 88.5% without reducing the sensitivity. But more importantly, if you look at the episode-based results, the last line there, the positive predictive value. So positive predictive value is, given that the test is positive, what is the probability that this is real, that this is really the disease? It went from 79.9% to 93.6%, and again, the sensitivity didn't suffer because of that. So AI is now being used to help with the diagnosis with these devices. Very, very interesting and exciting. This is something, even in administration, we could use it. So this is something we're implementing in our call center. My colleagues at White Plains are very familiar with this. What this does is this listens to the call between a patient and the call center personnel when you call in. And then it tries to analyze that call. At some point, in real time, you're talking too fast, you're talking too slowly, you're talking at too high a grade level. You should be talking about this particular topic or not another particular topic. And it's helping us right now to assess and to improve the quality of our call center personnel, but eventually it would help them in real time to improve their quality. We're also looking at agentic AI, so AI agents that can actually answer the calls and take care of most of the calls, integrate with our electronic medical records. So if you call and say, when is my appointment with Dr. Mercando next week? It can look it up in our electronic medical record, which happens to be the system called Epic, and then it can give the answer right there. So it doesn't even have to go to a human. And so we can sort of skim off the 40 or 50% of easy calls so that we don't have to staff for those peaks in the calls. The AI agent can help the human staff with that. Now, OpenAI has also been getting involved in the game. And just recently, they announced that they are partnering with models that are specifically tuned for healthcare. Okay, so they want to partner with healthcare. And they're already partnering with several large healthcare institutions across the country. And to the point where you can connect your electronic medical record to OpenAI, and it can help you with information. But right now, it is not HIPAA compliant, which means that they do not have to guarantee that your data is safe. So when you take your data and send it up to them, even if you strip out your name and your date of birth, there's information in a record, in the note that your doctor has written that possibly could identify you. And they're not guaranteeing yet that that data is not going to be used to train their models. So your health may end up as an answer to somebody else's question someday. So just be careful what you're doing. This is one of the examples where you have to really be careful. Claude is also getting involved in this. They just announced Built for Healthcare. So they're creating agents that can be useful in healthcare. Then there's something called open evidence that I want to tell you about. So open evidence is, think of it as a chat GPT for medicine. So it's been given all the usual chat GPT training, but also has been trained on other data, which is healthcare specific data. And it's designed to support healthcare professionals by providing evidence-based answers to very complex medical questions. Right now, it's only available to healthcare providers. It is HIPAA compliant. So if I wanted to feed a patient's data up there and say, what's happening with this patient, I could do that. Our institution does not yet allow us to do that. So I'm still taking some chances and doing, I don't do it, but I'm still taking some chances if I wanted to do it. But eventually they're ready to sign what's called business associates agreements with every institution that wants to. Open evidence can perform medical calculations. It can generate patient handouts, write prior authorization letters, as I'm going to show you in a minute, assist with differential diagnoses. In other words, what are the possible diagnoses this patient has, identify guidelines from established organizations like American College of Cardiology, and assess detailed drug label information to find subtle pieces of information. So if a patient comes in and says, hey, my pinky aches after you put me on that drug, I can actually ask it to say, has this ever been reported that a pinky can ache after somebody is put on a certain drug? Okay, so here's something that happened to me yesterday. I have a 93 or 4-year-old patient who's been on a particular drug for her atrial fibrillation now for about 15 years. She must have changed her health plan, Medicare health plan, and now the health plan asked her to get the drug approved. So I got what I dread, and every doctor dreads. I got a form to fill out for prior authorization for this drug. I thought it would be a slam dunk, you know. I mean, she's been on it for 15 years. She's 90-something years old. For God's sakes, you know, let the lady live with her drug. But no, they rejected it. Then they sent me this letter that said that if I want to appeal, I have to say why this drug is the right one for the patient and why these other 4 drugs that are on our formulary are not the right one. So I looked at this as, oh my God, this is going to take me a half an hour to write this letter. Okay? Well, what I did was I sent this prompt into open evidence. An elderly patient has been on Multac, that's the drug, for many years, and now her pharmacy benefit plan is requesting reasons why she cannot be on, and there, by the way, I dictated this, so it put THERE instead of the other there, are alternatives, including dofetilide, flecainide, propafenone, and quinidine. I'll tell you from a cardiologist's point of view, these are dangerous medications. They want me to put this poor old lady on. Okay? They want a statement requesting that the drug is medically necessary to treat her condition, which is paroxysmal atrial fibrillation, and the listed formulary alternatives are not effective. So please draft a letter justifying the use of Multac, which she tolerates well and which works for her arrhythmia. That's the prompt I gave to open evidence. So this is what it came back with. It said, the following letter provides justification, et cetera, et cetera, et cetera. It knew the generic name, by the way, for Multac, dronedarone. And that was what it said. And here's the letter that I could click on. That was the letter, 2-page letter. I have to tell you, I could not have written this letter better. Okay? It showed why this drug is the best one. It was the only one that is truly FDA approved for her condition. It then went through each of the drugs. So dofetilide, you have to admit a patient to the hospital for 3 days before you can, as you're starting the drug. It gave that as a reason. Flecainide, well, this is a lady who may have coronary disease at age 92. It's contraindicated. It went through every single one of the drugs. And so I just copied it, pasted it. I changed a couple of things in here. Actually, I was the co-author on one of the papers that it cited about how dangerous one of the drugs is, quinidine, and I did add that into the letter. And we'll see what happens. I'm hoping that I flawed them. I mean, they're probably going to know this was written by AI, but still, it was a well-written letter that really saved me a lot of time. So where is AI better than humans? Well, it's better at digesting and analyzing. And by the way, there are more examples of AI in healthcare. I can't show every single one of them now because then they're going to give me the hook soon. So I'm not going to do that. But so where is AI better than humans? Well, when you have massive amounts of data that have to be analyzed, that's where AI can be better, especially doing repetitive tasks like looking at chest x-rays and things like that. Tasks where if you're not really thinking as a clinician, you can get bored, you can get tired, you can get sloppy. So AI is better at medical image analysis. It's better at early disease detection. I showed you the example of atomo and cardiac amyloidosis. It's good at diagnostic assistance. Okay? It's not going to choose the drug for you, but it's going to give me some suggestions about drugs that may be good for you. And the physician will always be the pilot here, okay? The AI is going to be our co-pilot. It's good for drug discovery and development. You see these complex molecules. Is this going to do this? Is this going to make somebody grow a third arm? This kind of thing is where AI can be very, very useful. Genomics, personalized medicine, health monitoring, the amount of data your phone is generating every day, there's no way that I, as a clinician, can analyze your data, much less the other 100 patients I have who are using their phones, for gathering information, and also administrative tasks. But where are humans better than AI? Well, there are some places where we're still better. Okay, when there's complex decision making involving intuition, like that nurse with my grandson, things that evolve rapidly, that require creativity. AI is just basically giving you back what you gave it already, right? But the creativity is what's important here. Emotional support, compassion, empathy, that's where we can do better as human beings. And I have to tell you, if we have more time to be that way, I think we would be as physicians. So I think that's where it could help us. Developing confidence and trust in a physician-patient relationship. You're never going to really feel that warm and fuzzy about your AI doctor. I don't think, okay? Although I do like Ara in my car. Ara is my Grok car agent, but I'm still not going to, take her over my wife, for instance, right? I mean, I can't do that. And then there are such situations that require ethical considerations, okay? The AI doesn't really get the ethics, okay? It can only, again, go by what's been given to it before. And then healthcare leadership and management. So algorithms are never going to see how a patient looks or if they're avoiding a certain set of questions. I can tell when somebody doesn't want to speak about something. The AI might not be able to look at that subtle motion of the patient and really think about what they're doing. So AI is not going to replace humans. And you, by the way, you're going to hear this in every field, okay? So AI is not going to replace humans, but it's going to replace humans who don't use AI, okay? Essentially, that's what this is saying. So that means AI is going to give you a competitive edge. And it's going to give me as a clinician a competitive edge. Hey, I just wrote that letter in 20 seconds instead of a half an hour. But that's where it's going to come in. Okay, but what about the bad, right? We have to talk about that. So Elon Musk has been quoted as saying AI has a non-zero chance of annihilating humanity. Now, I have to have the electrical engineers explain what non-zero means, okay? So after the talk to them about it, because it sounds a lot worse than it really is. So non-zero just means, you know, the chance could be very, very small. But there is a chance that it could annihilate humanity. And Sam Altman, one of the co-founders of OpenAI with Elon, said AI could one day cause serious harm or worse. And it can. It can. It depends how we use it. And what about the pace of AI development? I'm going to show you something scary now. Okay, so in 2022, AI couldn't do basic arithmetic. And by the way, don't you guys back there, don't take your calculators out and do this. 7 times 8 is not 54. I'll tell you right now. Okay, but that's the answer that OpenAI would give you in 2022. It was very bad at math for some reason, or arithmetic for some reason. By 2023, however, it could pass the bar exam. By 2024, it could write working software and explain graduate level science. By late 2025, some of the best engineers in the world said that they had handed over most of their coding work to AI, okay? And on February 5th, 2026, new models arrived that made everything before them feel like a different era. Now, this is the scary one, okay? So OpenAI released GPT 5.3 Codex on February 5th, okay? And here's the quote from their description of the new model. GPT 5.3 Codex is our first model that was instrumental in creating itself. The Codex team used early versions to debug its own training, manage its own deployment, and diagnose test results and evaluations, okay? So those of you who've read that scary science fiction from the 60s and 70s, doesn't this remind you of that? Okay? So this is what we really have to start to worry about, and we really have to watch it. Now, one of the problems is if we have over-dependence on AI in medicine. This is one of the bad things. So I call it disuse atrophy. So if we depend upon the AI to make our decisions and to do what we need to do, something that's been called cognitive offloading, when we have to make that decision ourselves, we may not be able to do it. Our brains may just not be wired properly to do that. There's a danger that human physicians will not provide the necessary oversight to what AI is doing. What if the technology is not available? You know, the computer's not working, right? Call IT, put a ticket. You know, put a ticket in. That's what you got to do. That's what we do at our hospital. Put a ticket in. Who knows when that's going to be answered? But so these are the problems. Supervised versus unsupervised training. Can we trust the results? So unsupervised learning may be fine if you're trying to predict whether somebody's going to pay their mortgage off in 30 years, but not if they need to be put on a potentially toxic chemotherapy drug, okay? So we definitely have to keep an eye on it. Then there's this thing called hallucinations in layman's term. In physician term, it's called confabulations, and so that's where it just makes things up, okay? Like an article that my friend Tony sent to me from the orthopedic literature, which I will challenge him about afterwards, but it made it made things up. It actually made things up about references, okay? It cited papers that didn't exist. There was also another famous example from law where somebody submitted a brief to the judge, and the judge looked up the references, the case references, and they were all made up. But it looks exactly like it should look, but they were all made up. And then how do we test the results? And we really need to supervise the results. So we have this thing called explainable AI, where we try to get an explanation for how the AI is coming up with the answers it's coming up with. This is the challenge for those of you young people out there, to develop the ways to do this. We have to do this. I mean, one of the ways, for instance, is to take a model and deprive it of certain data and see if it comes up with the same answer. Okay, and that's, you know, it's tedious work, but that's one way of doing it. And that's the kind of thing that we're going to need a lot of that in medicine. So how can we be sure AI is doing the right thing? We have to test the output, not necessarily the input. A new type of clinical trial that we use in medicine and continuous real-world monitoring. We got to keep an eye on this all the time. Now, what about the ugly? Well, first of all, there's the medical legal issues. If anybody's a lawyer here, sorry. If something goes wrong, who's at fault? Right? Is it the developer of the model? Is it the vendor who sold the hospital the model? Or is it the physician? I'll tell you who I think is going to get sued. Okay, it's going to be the physician. And then, of course, there's privacy issues. And then should training subjects give informed consent or be compensated? So if I use your data to train my X-ray model, should I pay you for that data? Should I ask your permission to use that data? These are all unanswered questions. I'm not going to answer them for you here tonight, but these are unanswered questions. Who owns the model? Okay? And who's responsible for keeping it up to date? So my friend Tony sent me this article, but unfortunately the article was referencing a ChatGPT version that was 2 years old. And so what about doing it on a current model? The models are changing so quickly. AI bias, we've all heard about this. You may not appreciate it that much, but what data was the model trained on? Okay? If you train a model to do analysis of the kidneys in the Bronx, it will be different from the model you get in Westchester, okay? Because the populations are different. And that's going to happen consistently. So we have to be sure that whatever model we are using is going to be applicable to the population that we are dealing with here. And is the data generalizable? And can everyone reap the benefits? Are we going to deprive people because of access and cost issues? So let me just change gears a little bit. Why I like the ARCH concept, okay? I think it brings together Manhattan's strengths in engineering, liberal arts, business, science, and education. It really is combining analytics, research, creativity, and humanity. And its mission is to equip students with critical thinking skills. Okay? So people always ask me, why did you switch from electrical engineering to medicine? I say, it really wasn't that much of a switch. In fact, I don't go a day without using my engineering training. Okay? And it's the way I approach problem solving. It's how I solve problems. And I can tell you when I'm in the room with other clinicians, I do think different than those other clinicians. Where's the English person here in the room? Okay, right. So I think differently, Bridget, sorry. But if you remember the Think Different ad campaign by Apple, that was on billboards all over the country. But engineers do think differently, and that's something to try to instill in other areas. So this is a quote: "ARCH is collaborative by design. Faculty and students will work across disciplines to tackle complex problems with creativity, data literacy, and social responsibility." This was directly from Bridget. So let me just tell you a little bit about my multidisciplinary journey at Manhattan. So I started out in chemical engineering, saw the light very quickly, and by the first semester I switched over to electrical, which was really my true love. I mean, that's what I was very, very interested in my whole life. I did summer research on electrostatic precipitators, which is a type of device which cleans the air using electricity. And so even there, I combined the electricity with the environmental engineering, which at that time was under Department of Chemical Engineering here, and that was, it was very, very interesting. But then I took a course by Professor Robert Morrow, who is sitting at the table right there, who was truly one of my favorite but best teachers in my lifetime, and the course was on electrophysiology. And I fell in love with it because I said, wow, the human body has all this electricity running around in it. And so I said, maybe I should look into this more. So I was interested then in going into a field which was not named yet, called biomedical engineering. And I had to put my own program together, but they let me do it here. Okay? That was an interdisciplinary program. I was able to do biology, organic chemistry, and it was an interdisciplinary program. And then I eventually, after finishing here, I attended the Harvard-MIT program in health sciences and technology, which is, to this day, still in existence. It celebrated its 55th anniversary just a few months ago, but it combines engineering with medicine. There were 25 of us in the MD program. 5 of us were pure engineers. We knew nothing about biology going into the program. The rest came from very diverse backgrounds, including a history major. We had biochemists. We had all kinds of people in there. And we learned from each other. And that was the idea behind HST. So why is Manhattan so well positioned to lead in this kind of thing with AI and interdisciplinary education? Well, first of all, when you're here at Manhattan, you get a well-rounded Lassallean training in arts, sciences, ethics, culture, religion. The schools are tightly integrated, so especially with Arch, you'll be able to go between schools and take courses in different schools. There's supportive and resourceful alumni. Take advantage of the alumni, like you took advantage of me to come and give this talk. Take advantage of your other alumni too. And the benefits, here's the secret sauce, the benefits of a world-class engineering school. There are very few schools in the area. Everybody wants to do AI, but very few have engineering programs, especially such a world-class engineering program as this. So I challenge Manhattan to be a leader in preparing students, in educating others, in fostering the ethical use of AI, in being a leader in multidisciplinary use of AI, and be a leader in innovation. So I thank you for your attention. I hope that I proved that the good is much better than the bad plus the ugly. And certainly any questions, I'd be happy to entertain them now. Thank you.
So we'd like to invite students up here to ask certainly the first question, hopefully all 3. Anyone in the audience? Questions for Dr. Mercando? Oh, come on, guys. Yes.
No, she's not a student. Wait a minute.
So I'm not a student, but I just wanted to say that as an old woman who has been in this space for a very long time, we look up to clinicians like Dr. Mercando to teach us what the next generation will be doing for us. So thank you for that terrific talk, and I'm just glad that you're moving this forward in the healthcare organization we work in. I appreciate it. Thanks.
Thank you.
Other questions?
Now, the students had a lot of questions when I met with them before, so if you want to ask one of those, you can, for the benefit of everybody else.
All right, I'm coming for you. You can also, right, yell out, Farah, I see you. Mahad, I see you. This is a fun game. Maria, do you want to ask the question you asked this afternoon?
That's okay. We don't have to have questions. That's fine.
Ask about the radiology. Okay, replacing subspecialties.
How do you feel about AI possibly replacing specialties like radiology?
Yeah, so you want to be a radiologist, right? It says
Well,
you're...
I was looking into it.
Yeah. I don't know if it's going to replace completely, but I think that there will be some specialties where AI will be used more than others. And I think radiology is one of the major ones where it's going to be used. I can tell you right now, we can't get enough radiologists in this area. Neither Montefiore nor White Plains can hire enough radiologists. So we have a shortage. So right now, I feel that AI is going to help the current radiologists to read their studies faster, more accurately. But I think that we're a few years away from where the radiologist is going to be completely replaced, if ever. So you're still going to need some radiologists. Lawyers will still need somebody to sue, and you have to be looking over the shoulder of the technology. But that's a very good question. The other question somebody asked before about anesthesiology, I think that's an example of a specialty where you will not see AI replace too much, okay? Because I don't know if we want robots giving us our propofol when we have our colonoscopies. So, I think that, we're probably still going to be using, more humans in some specialties than others. But I think in every specialty, the human, at least for the foreseeable future, will still need to look over what the AI is doing.
I'm interested in becoming a physician's assistant, and I was wondering, how will AI change, our relationship with the physicians?
How would it change? I don't know if it's going to change the relationship between physicians and physician assistants that much. I think that it may allow physician assistants to even go beyond what they're doing already, because you'll have the assistance of AI there. And so I think it can only be beneficial to physicians' assistants. But again, physicians' assistants and specialty-oriented physicians who do procedures, for instance, a lot of that is still going to be necessary. So we're still going to need humans to do that.
He's thinking.
Hey, I have a question about pre-health majors. Right now it's so hard for undergraduate to get clinical hours, to get shadowing, to get involved with hospitals, and then with AI it gets even worse because it's a whole new fight. So my question would be, what's your advice for people graduating now still as a pre-health major to get more in contact with the area?
To get more,
be more familiar with the area within this whole AI wave.
so when you say the area, you mean the geographic area?
I mean the medical field.
The medical field. So I think, again, if you're interested in pre-health, please do it. We need lots of workers in healthcare at all levels. So I would not dissuade you because of AI coming along. I think that, from the things that I've said, we're still going to have to keep an eye on the AI. You may be going into a field where you'll be using AI, where you might be training AI, et cetera. So I think that if you want to do it, okay? But, somebody asked me before, they went between biology and computer science, and now they're doing biology with a minor in computer science. You think I should keep that minor? I said, of course you keep that minor, right? Because computer science will give you that edge to be able to do whatever you want to do later on. So I think that, again, in the ARCH initiative, you can do that. So I would say try to be multidisciplinary, do what you want to do, what you have a passion for, but definitely learn about the AI, because you will be using it in virtually every healthcare aspect when you go forward. Okay.
Thank you, everyone, for your questions. And I'd just like to extend our thanks once again to Dr. Anthony Mercando for being our inaugural ARCH speaker. Thank you for everyone for attending this wonderful talk, students especially, and our invited guests. I hope you'll join us next door for a reception afterwards.